right, well, welcome everyone on Facebook. Thank you for your patience, and welcome to everyone who is joining on the webinar. This is Sisters Network Incorporated. We are excited today. It's a beautiful day on Saturday, and we are hosting our Survivorship and Leadership Conference series, the final one in the conference series. And today we're going to do Know Your Her Story and Ask the Doctor. And we're very excited and pleased to have one of our very, very special friends, a medical expert friend, Dr. Vivian B., who I'll introduce in just a moment. But I want to just take time to say thank you to all the participants who are coming online. We have a wonderful 1-hour session. We will have an opportunity to engage directly with Dr. B and Mrs. Jackson in a moment as well. And I am Caleen Allen. I am the Vice President of Sisters Network. And again, welcome and thank you for being here today. And we couldn't make some of our programming possible without our wonderful sponsors and friends. And today, Pfizer is one of our top sponsors for this particular webinar. We thank them for their continued partnership and friendship and support of Sisters Network, this particular endeavor, as well as our town hall State of Black Crisis. They have been a wonderful partner, as well as CGen and ASI, who are both long-term partners, and we appreciate their long-term friendship support and just making sure that we have the resources to bring the important information and experts and so forth to you. So thank you again to Pfizer, CGen, and ASI for today's Survivorship and Leadership Conference series, the final one, Know Your Her Story, Ask the Doctor. Before I get started, I will introduce our speaker, but I also will let you know that our founder and CEO, Karen Eubanks Jackson, will bring some greetings in just a moment. So Mrs. Jackson, I'll let you bring the greetings and then I'll come back and introduce our speaker.
Well, no one mentioned about being on mute. Thank you all. Good afternoon again, and welcome to Sisters Network National Webinar. We thank you for joining today. I have good news to share. And the good news is we can praise God that we are all here again another day to come together in sisterhood. The spotlight is shining bright on the Black breast cancer crisis. It is a great time to be Black in America. And you're going to say, really? Yes, really. The health institutional injustices that we all face at different levels has now become apparently clear to others. What we knew, others are now understanding the situations that we find ourselves in some of the institutions that we all go to. I applaud you and thank each and every member of the Sisters Network affiliate chapters for your powerful impact, in fighting for Black health in the local communities across the country. As a survivor myself, an advocate and leader and author, I have spent a quarter of a century fighting, good fight, to bring Black breast cancer to the forefront. The late Congressman John Lewis, we all know, said, doing good trouble. Sisters Network Inc. has been doing good trouble for nearly 3 decades. So I applaud you and the women who are behind Sisters Network. The fact that Sisters has weathered the storms and challenges in the racial injustice, the environment speaks volumes about who we are today and the impact and the legacy we pass on to the next generation. I would like to say that because of this legacy, it is so important for us to continue to come together, hopefully soon in person, and continue the webinars, which are so educational. And happy to have Dr. B with us again. Thank you all, and please share the information with others. Thank you.
This mute and unmute is something else. Thank you, Mrs. Jackson, for taking time to talk about the social injustices that we have all faced. And Sisters is definitely at the forefront, and we will continue to be at the forefront in the fight against breast cancer. For those who don't know a little bit about Sisters, I'm just going to give you just a brief overview. Sisters Network was established in 1994 by Mrs. Jackson. It's headquartered here in Houston. We have over 25 affiliate chapters around the country, and hopefully some of our chapter members are on today. And if you are, please in the chat, just shout out where you're from. I see that the Southeast West Wisconsin chapter is on board, and I'd like to recognize them, but we are here to help. We have a few more new chapters coming on board in the next month or so. We're super excited in some other cities, Boston, Montgomery, Alabama, Phoenix, and Rochester, New York. And I believe some of those ladies are on today listening, but they are going through the onboarding process. So we're super excited that we are growing and still sustaining and serving the community. And thank you to the Sisters Network, Central Virginia. I see you in reading Pennsylvania, Chicago's on board. And so we'll continue to acknowledge you throughout the rest of this presentation. I can't wait to get to our speaker. Let me just tell you a little bit about this dynamic woman. She is just a wonderful supporter and friend of Sisters. When we call, she comes, and we just sincerely appreciate you, Dr. Vivian B. So let me tell you a little bit about her, our speaker today. Dr. Vivian B. is the Section Chief of Breast Surgical Oncology at New York-Presbyterian Brooklyn Methodist Hospital, and is Assistant Professor of Surgery at Weill Cornell Medicine. She is a board-certified surgeon who completed her breast surgical oncology fellowship training at UTMD Anderson Cancer Center in Houston, Texas. She is also a breast disparities researcher, educator, community outreach leader, entrepreneur, and best-selling children's author. Dr. B came from a humble background. She was born and raised in the inner city of Washington, D.C. as the middle child of 7 children, so it's a big, big family. Committed to serving underserved populations, Dr. B attended Morehouse School of Medicine, whose mission was to serve the underserved. There, she was met with multiple awards and recognitions for her dedication to eliminating healthcare disparities. After her matriculation from Morehouse, Dr. B continued on to Medical University of South Carolina General Surgery Residency Training Program in Charleston, South Carolina. While in Charleston, Dr. B continued her work in addressing breast cancer disparities through research and health initiatives, presenting her research at major meetings across the world. Dr. B was then awarded the highly coveted Breast Surgical Oncology Fellowship position at UTMD Anderson Cancer Center in Houston that we spoke about a moment ago. She then served as the breast surgical oncologist in the Division of Breast Surgery at MD Anderson Cancer Center at Cooper in Camden, New Jersey, where she chaired the inflammatory breast cancer program. Dr. B's primary research efforts have focused on modifiable risk factors and outcomes in ethnic populations. In the community, her primary initiative has been to bridge the gap between multidisciplinary breast cancer treatment and community barriers. She is doing just this with her most recent multi-institutional community outreach grant through the American Cancer Society and Pfizer. Yet again, our wonderful partner Pfizer doing the great work. This grant was specifically designed to address breast cancer disparities in African-American women through increased breast cancer screening, community, and patient education navigation. Recognized as a rising star and a top physician in her field, Dr. B was awarded the prestigious American Medical Association's National Minority Quality Forums Brain Trust Top 40 Under 40 in Minority Health for her dedication to community outreach, research, and commitment to eliminating breast cancer disparities. In 2019, she was also named Best of Healthcare by South Jersey Business Magazine. She is the recipient of a host of awards and accolades for her accomplishments and commitment to her patients and the community. Dr. B is garnering recognition in the press nationally as well. She served as a guest speaker on NPR and has been featured on NBC, the Washington Informer website, the Black News website, as well as the Catalyst and Brooklyner newspapers, just to name a few. In conjunction with being at the forefront of patient care and breast disparities, Dr. B remains passionate about her community. She is the founder of GLOSS, Girls Loving Ourselves Successfully, a program focused on mentoring middle and high school girls. She is also a proud member of Sigma Gamma Rho Sorority Incorporated, which is a wonderful partner of Sisters Network and our Mammogram program. So shout out to Sigma Gamma Rho ladies. Understanding the importance of representation and diversity in books, she founded the Chocolate Kid Chronicles, publishing her first children's book in the series in an Amazon bestseller, Please Don't Touch My Magical Hair. Ladies, I'd love to welcome Dr. Vivian B., who is just a wonderful, wonderful breast expert, and we'd love to hear from you today. Thank you, Dr. B. The floor is yours.
Well, thank you so much for having me. Listen, at the beginning, you said that Dr. Jackson called, Ms. Jackson called, and I said, absolutely, because I don't say no to Ms. Jackson. So I just want you to understand that it is always a pleasure and a privilege to be here. And, you know, we often talk about breast disparities. When I come in this setting and in this forum, it's just beautiful to be surrounded by other women of color so that I can exercise what I believe is my purpose in fighting and eliminating breast disparities. Now, I know that we're going to have more sort of an interactive forum here, and so I'm going to encourage you to post your questions in the chat. I'm going to lead, however, with a presentation just to kind of get the conversation started, but I will continue to sort of check the chat to see if there are questions that are applicable and pull them in as I show you some slides, okay? So let's get it started. Okay, let's see. My computer was slowing down earlier, so let's see if it is still doing that. You can see these slides, yes? Okay, but you're not seeing the speaker view. There we go. Okay. All right, so so this is really Know Your Herstory, and you're gonna ask me some questions, and like I said, I will check. And Caleen, if you see some questions that I need to sort of stop and address, please please signal to me. So I always like to start with some statistics for breast so that we all are aware. We know that breast cancer is the leading cause of new cancers diagnosed in the United States. We know that it is the second leading cause of cancer-related death in women in the United States. We should know, and I often say, it's important to, I can't underestimate the importance of going through signs and symptoms for breast cancer so that I can trigger your mind and remind you so that when we're in our family forums, we are on GroupMe or, you know, I just sent my family a message, did you get your mammogram? And here are the signs and symptoms to remind them. And that's a quarterly thing for me, that signs and symptoms for breast cancer are lumps, change in the size of your breast, swelling and thickening. If your breast starts looking like an orange, that's not what's normal, so you need to go see somebody about that. Nipple discharge, changes in your nipple like retraction and going in, scaliness that sort of looks like eczema would be a sign and symptom, skin irritation and dimpling, and also feeling something underneath the armpit. So breast cancer mortality, just sort of some high points for us to remind ourselves why we're here. We know that breast cancer in Black women, we are 40% more likely to die from a breast cancer diagnosis. Now, that doesn't mean that we always are going to die if we are diagnosed with a breast cancer diagnosis, and that's why it's important to know your history as well as to get screened, and we'll talk about that. But we know that the breast cancer burden of Black Americans is the higher mortality or death rate due to advanced age, advanced stage at diagnosis, younger age at diagnosis, and often having what we call a triple negative breast cancer, which portends a worse prognosis. And, you know, I'm not going to go through this slide ad nauseum. What it really is set to illustrate is that while the incidence of breast cancer over the years has sort of stayed study, we know that the divide in mortality for Black and white women certainly has happened, and has happened over the years since the 1980s, where treatment therapies were actually geared more towards the tumor biology of white women. And so my goal here is really just to talk to you about what we can do to equip ourselves to combat the breast disparities crisis. We know that this crisis is multifactorial. It's due, again, to the triple negative breast cancer that we are often diagnosed with. You can't control that. We know that it's due to social economic status and social determinants of health, and oftentimes we cannot control those. Comorbidities, I think we know that we have to eat healthy and do better, just as a race, but sometimes you can't control that. Screening is something that we can control, and so I want to, again, encourage you to stay on top of your screening and encourage your family members to do so. Medical mistrust is something that I have dedicated my career to sort of combating, because medical mistrust exists, and it exists for a reason. As a Black woman who sits at the table, I make it my duty to speak up so that my white counterparts and others who are there can understand that that we have to do better within the medical field to gain that trust, to be trustworthy. Okay, so what about etiology and risk factors? So this kind of plays into the know your history, your herstory. So we know that in breast cancer, cancers due to many causes. It can be due to individual issues, environment, and unknown factors, but we also know that there's a hereditary component to breast cancer. The vast majority of breast cancers, to be clear, are sporadic, meaning they happen without a known family history. And I'm going to say that slowly again, because I can't tell you how many times I hear patients come in who have been diagnosed with breast cancer and they say, well, nobody else in my family had breast cancer. That actually is the majority of the time. No one in your family will have had breast cancer. But if you do have a history of breast cancer, ovarian cancer, or other cancers in your family, it's important that we know that, because we know that there is potential risk associated with that. Some other risk factors that that I want to highlight for us is dense breast. And I know Ms. Jackson and I have talked about dense breast and the importance of being your own advocate to get an ultrasound and sometimes an MRI. And so I'm bringing that back at the beginning of this year to make sure that everybody knows that Dr. B supports that getting a mammogram when you have dense breast alone is not enough. And, sometimes it's important for you to hear that from a medical professional, as well as Ms. Jackson and others, just to really go and feel empowered when someone tells you no. You have a right to get an ultrasound when you have dense breast. There are other risk factors that are modifiable, meaning things that we can take control of: alcohol and alcohol use, smoking and tobacco. Of course, we know those, but also understanding the family history. And so, again, we talked about the Black cancer burden on breast cancer. And so one thing that I always bring back, and this is always a point of discussion, and so I thought that I would pull this up, Ms. Jackson, if you're okay with this, in that the role of social determinants on health inequalities, and certainly the role of social determinants on breast inequalities, centers on racism in this country, and it has led to socioeconomic issues, and we cannot be silent about it. We cannot sort of ignore it and continue to blame Black and brown individuals as to why we are dying at alarming rates from cancers and other comorbidities. The environmental exposure that we are subjected to is all centered on racism. The stress in this country that we constantly are, I can't even turn my TV on. I try to stay away, right, because of my mental, I have to protect my mental. And so, that also has to factor in. And can lead to health behaviors that sort of, yes, we should have control over, but it all sort of is embedded in racism that got us here. Again, access to health services is centered on racism. And so, knowing where to access and how to access, and it's very different across the country. But that's something that we have to sort of, improve upon. And access to testing and screening, that's how you can be empowered, getting that access, knowing your rights. And overall, we hope that that can improve health outcomes. Now, I love Dr. Maya Angelou, who said, I have great respect for the past. If you don't know where you've come from, you don't know where you're going. And so again, this is why it's important for us to know the history or the herstory of it all so that we can combat and be our biggest advocates. Part of that is knowing your family history and knowing that if you have a first degree relative with breast cancer, you have a twofold increased risk of having a genetic mutation. We know that genetic mutations, again, only account for about 5 to 10% of all breast cancers, and that hereditary breast cancer is associated with young age. Again, Black women are often diagnosed at a young age. Triple negative breast cancer, again, we are often diagnosed with triple negative breast cancer. I also will take a moment to say that it's interesting that when we do our genetic testing, I serve a very diverse population, and I'm actually publishing soon some data that supports the fact that when we provide access to genetic testing for Black women, not all the time do we find these genetic mutations, even though there may be a substantial family history. And a lot of that goes back to the racism and the inability to have access to those testings and those mutations being identified many years ago. And so I treat those patients very aggressively, meaning I screen them, I follow their breasts very closely. I think I have a few slides left. So associated genes with the hereditary breast cancer, we've heard of BRCA, but just know that there are other gene mutations that also should be checked for. So do not just settle for a BRCA test. There are extended panels that you should have access to, and speaking with a genetic counselor is important. And it's important that we identify those who have genetic risks because we may do something different, right? If I find that you have a genetic mutation, I may be talking to you about looking at your breast more often with an MRI every 6 months, or coming in to get a clinical breast exam. I may be talking to you about a prophylactic mastectomy, or removing the breast to decrease your risk of developing a future breast cancer. And so there are things that actually you can be empowered, right? So if you know what your risk is, then you can make decisions ahead of the game before even being diagnosed with breast cancer. Now, I want to pivot to breast screening because I also find this as an important part that we have to talk about, and we can certainly talk about it more when I open up the discussion. But you may have heard some organizations say, oh, you can start screening at the age of 45, or, every couple of years. To be clear, that does not apply to Black women, okay? So we want you to get screened at the very least at the age of 40, and sometimes earlier. To start, all Black women should have a risk assessment at the age of 30 to determine if you are at high risk and if you should have a mammogram sooner than that. And certainly if you have a family history of breast cancer or other cancers, seeing a genetic counselor or a breast specialist to help determine your risk, and if you need to sort of have more things done before the age of 30 is going to be important. I also point out that Black don't crack. And so the saying that stop your mammogram at the age of 75 does not apply completely to us, right? It does not. My grandmother is 94, just got her booster shot today, fly with her fur coat. She went in to get her test in Washington, D.C. I just saw a picture pop up. She looks like she's 60, right? So I always say to patients, if you are willing to go and get the mammogram and willing to have treatments if cancer were found, and your expectancy is greater than 10 years, then you should continue your mammograms, okay? We need our grandmothers still here. And so I want you to pass that on. And then what about clinical trial participation? And I know that there are questions about this, and I just will pop this up to say, there is a historical foundation that we cannot and should not, quite frankly, ignore as it relates to clinical trial participation not even participation, clinical trial in this country. And we know that we have been treated unfairly. But we also know that clinical trials in this day and age are an avenue for us to be represented, for us to actually receive the latest treatments. And if you think about it like this, any person or any researcher who is putting their name on a clinical trial, they want to see it do well, right? And so they're going to make sure that you are receiving all of the therapies and treatments on time. And they're going to be following, any adverse effects because they want to be able to say, well, this X, Y, and Z works. And so I really encourage you all and us all to participate in clinical trials so that we are represented, so that the medications that are recommended can be applicable to us. We are not all the same when they apply it to others. We're not represented. It's hard to sometimes determine whether certain therapies are going to be applicable to us. And so with that, I will just start with a couple of questions to get the ball rolling. So there was a question about how can the medical community engage with patients at a community level to enhance diversity and inclusion in clinical trials. And I think part of that is centered on the fact that we have to be trustworthy. And there's multiple factors to that. So you have a systemic part, you have a patient level factor, and then you also have clinicians. And so from a system standpoint, the system has to address the fact that there are historical issues that exist and really make an effort to go out into the community to engage and to show that, that clinical trials are important and that having you on a clinical trial is also important. But as individuals, we also have to seek out these clinical trials. We have to know that these are our right, quite frankly. And so being empowered, you can go into a hospital system and they may never mention to you that you are a candidate for a clinical trial. Another study that I looked at this year, over the last couple of years, is in my own hospital system, which is in a diverse community. The clinical trial accrual rate has gone up substantially with some forms of implementation that we have put into place to remove bias from clinicians, so that it's not just one clinician offering a clinical trial to a patient, but rather there is a whole group that's responsible. And of course, my eyes are always on every patient to make sure that they understand that they have the opportunity to participate in these clinical trials. And so we empower patients. And so that's what we have to do. As a hospital system and as clinicians, we have to engage the community, but we also have to build our trustworthiness in doing that and empower patients. Are there other questions?
Yes, Dr. B.
Yes, ma'am.
There is a question for you. One of the participants was genetically tested in 2016. Does one need to be tested every few years as new genetic testing panels are improved?
That is a great question. So the answer is not every few years, but the first thing is I always ask, where did you have it? And you don't have to answer this, but where did you have it? Did you have a genetic counselor, someone who's actually going to be following up on any changes to that genetic panel? Because every year it does change and update where some, what we call variants of unknown significance, meaning they don't really know whether it is a true risk factor, whether that has been actually upgraded to the full mutation. And so having someone follow that list is helpful. But yes, I do recommend that at least every 2 to 3 years, you're speaking to a genetic counselor or a breast specialist so that they can look at where you had it tested, what type of testing you had, right? Sometimes, again, I hear women in the community say, I got tested, but it was only the BRCA gene. But they're like the full panel is in the 90s, right? So, making sure that extended panel has been done. And so yes, you should have a conversation, not necessarily getting the test, but having a conversation to see if you should get the test.
Thank you. Is a certain type of cancer more prominent of reoccurrences?
Not with reoccurrences. We do say that when we think about reoccurrences, let me just talk about that. When we talk about reoccurrences, we're thinking of local reoccurrence, regional reoccurrence, and recurrence that is metastatic. We know that the higher risk phenotypes, like a triple negative breast cancer or even a HER2 positive breast cancer, are more aggressive. And so we try to treat those at the onset aggressively, oftentimes with chemotherapy or HER2 targeted therapies to reduce the risk of a recurrence. The regional metastatic recurrence, the regional recurrence is significantly decreased with radiation if you have a lumpectomy, for example. And so, but to answer your question, hormone positive versus triple negative, there's no data to support that either one is going to have a higher recurrence rate, as long as you have gotten all of the, as I say, the tools in the toolbox to treat the initial breast cancer, which can include surgery, radiation and/or radiation, and sometimes chemotherapy, or even hormonal therapy, depending on if you have hormone positive versus triple negative versus HER2 positive disease.
Thank you.
Dr. B, I'm gonna insert a couple of questions from the chat just to make sure we don't overlook them. Can you tell us why? It says, can you tell us why do our nails and skin turn dark and with some chemotherapies? Which therapies make the skin and nails turn dark?
Yeah, so it's the Taxols are the ones that that do that, and it really is a huge problem that we often see, in our patients who are receiving Taxol therapy. And I say it's a huge problem, not because it necessarily is causing pain, although it can cause what we call neuropathy as a side effect, but it's the sort of constant reminder that you're undergoing chemotherapy. And I don't know if Ms. Jackson, I'm gonna pull her into this a little bit, if there are, because I think that there's more that we can do. Some women get their nails done and try to hide that, that discoloration. But if you have any advice from just, survivors and patients who have gone through the discoloration and coping.
Well, some of the ladies have shared that the more stimulation, meaning massage or manipulation of the hands and the feet, the toes, helps to circulate and get the dark. It's not as dark as when you don't do anything. So somehow we're not explaining it, but circulation does help change the color.
Okay. All right. Another question is, would you talk about HER2 diagnosis and what that means? And I'll turn it back over to you.
Sure. So HER2 is actually a protein that that when amplified can cause cancer cells to grow fairly quickly. And really about not even 10 years ago, when we had patients who had HER2 positive disease, so it can be negative or it can be positive, HER2 positive disease, it was really not a great diagnosis. And then came through clinical trials the advent of these targeted therapies that target the HER2 protein and sort of turn off that amplification. And we found that now, even for patients who have HER2 positive disease, when they get that HER2 targeted therapy, oftentimes they have a complete response, meaning the cancer is targeted effectively with the therapy, and survival is improved. And so that's what HER2 means. If you think about it, so the way that I sort of explain it is you have estrogen, you have progesterone receptors, and then you have HER2 to think about. And those are sort of the trilogy. And so when we say triple negative, it means that all three are negative. And then when you have the HER2 that is positive, that's what we call it HER2 positive. And the estrogen and progesterone can be positive or negative. And then you can have estrogen and progesterone that are positive and HER2 is negative, and that's when we call it hormone positive disease.
Dr.
And
B,
yes,
okay.
And I was going to say, and taking B6 and B12 does help neuropathy.
Okay, that's
a
good
great
to know.
point.
I've been asked on many occasions about a typical dysplasia that is not really discussed by the oncologist much, but we do seem to have a typical dysplasia.
Yes. So it's interesting because I put it up on one of the slides, but I did gloss over it. But atypical ductal hyperplasia, I actually see a lot of atypical ductal hyperplasia. So thank you for stopping me and calling it out so we can talk about it. The way I explain atypical ductal hyperplasia or atypical lobular hyperplasia is I'm very visual. So if you think about, let's just say a yard with grass, right? I sort of paint the picture, that's your breast. And you may have a little weed that pops up. Sometimes that weed looks abnormal and it doesn't go with the rest of the pattern, right? That's when we call it atypical. Atypical ductal hyperplasia can increase your risk of having an underlying breast cancer by about 15%. And so we do either follow the atypical ductal hyperplasia, and you may say, well, how do you know that I have atypical ductal hyperplasia? Well, it always starts with screening. You get a mammogram, plus or minus an ultrasound, and let's say that on the mammogram, there's some calcifications, and the radiologist recommends a stereotactic biopsy. You have the stereotactic biopsy, and that biopsy comes back as atypical ductal hyperplasia. Okay, so now we're here. It's not a cancer, but it's high risk. It's not as high risk as having a BRCA mutation, for example, but it is high risk. And so we know that with that, we need to follow the breast either very closely and or excise, remove the atypical ductal hyperplasia. Sometimes we often will also put patients on what we call chemoprevention pills or pills to block the estrogen and progesterone to decrease that risk of developing a future breast cancer. So that's what atypical ductal hyperplasia is. If you go from one spectrum to the other, you're starting with benign breast disease. Then you may have some hyperplasia, which are those weeds that sort of they fit in, so you don't really recognize that they are atypical. And then you go to the atypical hyperplasia, where it's like, okay, that's kind of doesn't match up with the rest of the grass. And then you have ductal carcinoma in situ, and that's the vine that has now started to crawl on the fence. Okay, in the yard. Y'all follow me? And then when it crawls over the fence, that's when we add invasive. Okay, so that's how I explain. That's the progression of what can happen in your breast. See, now you've had a whole consultation with me.
That is a beautiful explanation.
We've got a lot of great questions, and Bernadette from our Detroit chapter, who's always so gracious and helpful with fielding these questions. I'm going to turn it back over to you, Bernadette, but we've got probably 11 questions in Q&A and a lot of questions in the chat. So we're going to try to get through them as quickly as we can. Bernadette, go ahead and.
Okay, thank you so much, Caleen. Dr. B, whereas prevention is great, for those of us who've already been diagnosed with cancer, what advice do you have for us?
So for those who have been diagnosed and treated, you still can think of preventing future, right? And sort of being actively involved in your survivorship journey. And that means if you have had a mastectomy, you still need to have a clinical breast exam at least every 6 months, so at least twice a year. If you have one mastectomy, you still have another breast. You still need to have that mammogram to look at that breast. You know, if you need to follow up with your medical oncologist, depending on what type of therapy you're on, staying active in doing that. That's important. And so those are really the things. And then prevention is also recognition, right? So if you recognize that something is wrong with your body, you know, being an advocate for yourself and you know, raising your hand and saying, hey, this is different, let's check it out. That's how you can sort of be an advocate for yourself.
Thank you. Is there a blood test that you would recommend as an oncologist post-treatment to analyze potential reoccurrence for an early diagnosis? Looks like that person was diagnosed with stage 1A.
Gotcha. So typically, and there are various institutions that treat or would answer this question differently. But for an early stage breast cancer, we typically don't recommend following with a blood test. For more advanced, there are some programs that will follow a blood test, which at MD Anderson, that's where I trained, we would do. I would say have a conversation with your oncologist and see, you know, what their thoughts are in regards to that question.
Thank you. Where can you find resources for clinical trials that focus on Black breast cancer survivors?
That is a great question. I was just looking over at my other computer. Let me put some in the chat. There's an African American woman who is in charge of the NIH and is really pro survivorship. If I can't find the link that she has shared, I will certainly share it with Ms. Jackson and Caleen, who can then get it out to the group. But that is a great question. Clinicaltrials.gov is certainly one, but there are other websites that really focus on the Black breast and Black people and getting us involved. There's actually a big campaign going on, and just slipped my mind, but I will send that website. Ms. Jackson? Oh, I thought you unmuted yourself.
Dr. B,
I'll send the websites. Mm-hmm.
there's a question in here that I think is really important. This woman says that she's an 18-year breast cancer survivor with a history of breast cancer in her family. Her daughter is 27. There's a history of breast cancer on the paternal side as well. At what age should she start to get her first screening? And that question's important to me, particularly because I have a 27-year-old, 27-year-old, whoops. But also because we're having, we talk about young women, Black women being diagnosed so early. So can you address that for us?
Absolutely. So we always say 10 years from the youngest age. There's two different ways of addressing this. So one is if you have a genetic mutation, a known genetic mutation, then your daughters and your son should have screening no later than the age of 25. And that is having a genetic consultation. They may have to have genetic testing. If you've had a diagnosis of breast cancer, you've never had genetic testing, find out if you are a candidate for it, if you're eligible for it. And I don't want to get into the eligibility because there's different societies, but find out if you're eligible for it, because then that can help dictate what needs to happen with your children. Okay, so that's the first step. Let's say you had the genetic testing and the genetics were negative. And you were diagnosed at the age of 40. Well, technically, your child should really be screened at the age of 30. Let's say that you were older. Then I still believe, and this is what we talked about, that for Black breasts, we need to screen as early as 30. But screening at 27 certainly doesn't help. And what does that mean? It means having a consultation with a breast specialist so that some risk models can be run to determine what that particular risk is. We can calculate lifetime risk, we can calculate 5-year risk, and help determine when, for example, a mammogram and ultrasound is necessary. We also sort of plan like this, right? Because you don't want to start doing mammograms too early, because you have our radiology colleagues who say you don't want to exposed to radiation too soon over a lifetime, et cetera, et cetera. But if you know what the risks are, then it's helpful for making that determination. Did that answer the question?
Yes.
Because there's different pathways, but yes, that's the earlier the better, put it that way. And let me also say, I was just talking this week to some medical students, and I was just reminiscing on how I had a pediatrician who was a Black woman from the islands. And I just remember being 12 and she taught me how to do a breast exam. I remember when, I was able to sort of find my fibrocystic breast, and she took it seriously. And empowered me. And so I will just say, regardless of the age, all young women should know how to do a breast exam, should have that kind of relationship with the physician, and should have the screening as well.
Thank you. What is the recurrence rate for someone who had a lumpectomy with radiation and hormonal treatment?
So we need more info than that, but I will say for early, so it's based on stage. The first thing is, it sounds like you have gotten the appropriate therapy. It sounds like it's a hormone positive breast cancer. I don't know the size. and you've got the radiation with the lumpectomy, which we know radiation decreases the risk of recurrence. The survival is very high for stage 1 and 2. We're talking 90%. And stage 3 is about 20 percentile less than that. So if it were early stage, you have a great survival, and you receive the radiation, so your risk of recurrence was decreased significantly.
What is the best treatment for triple negative breast cancer?
Triple negative breast cancer also depends on the size, and most often an anthracycline is included, which is a very strong chemotherapy agent. With Taxol, the medical oncologists have different cocktails, as I call it, that they use based on different features and based on how, honestly, they've trained. But the cocktails that, the main cocktails often consist of an anthracycline, depending on your comorbidities. If you can, tolerate an anthracycline, otherwise they do the Taxol and, for example, carbo. But they're different cocktails. There's also a difference between what we call neoadjuvant chemotherapy, and then post-surgery, what we call adjuvant therapy, which then often offers other treatment modalities. You may have heard of immunotherapy. So immunotherapy is also a treatment strategy that we use for triple negative breast cancer.
Thank you. Should breast cancer survivors have their sons tested for cancer?
Yes, ma'am. The answer is absolutely, positively, without question, yes. And that is a great point, because we often leave our sons out of the picture. But if you look at Beyonce's father, right?
Mm-hmm.
Mhm.
He had a BRCA mutation. So absolutely.
Great. Are there any vitamins or supplements that a breast cancer patient can take while on medications such as tamoxifen and Lupron?
Sorry about that. So is there a vitamin?
Any vitamins or supplements?
So yes, the answer is yes. There are vitamins and supplements that you should and can take. There's some that we want you to stay away from. I'm going to avoid naming particular vitamins, because it really, you should have a conversation with your doctor so that they can look at all your medications. I will say that that for Black women, we are notoriously low in vitamin D. And we know that there's some studies out there that support having adequate vitamin D levels for energy, and certainly we recommend vitamin D for our patients. It was mentioned B6 and B12 if you're receiving chemotherapy. So those are the sort of mainstay, but there are others that, a conversation with your doctor. Now, the other thing is there exist medical physicians who do more sort of integrative medicine, and if you have that near you, look into it, or just look into it to see if somebody is near you, because those physicians are excellent in looking at all of your medications, looking at your lab work, looking at the therapies that you're going to receive, to make recommendations of integrative, not alternative, but integrative medicine therapies.
Great. Do you recommend an MRI ultrasound for women who had a mastectomy with reconstruction? If so, how many years post-reconstruction?
So that's also a hot topic for patients who've had a mastectomy with reconstruction. And I'm assuming if the reconstruction is an implant, it used to be 3 years, then it went to 5 years. And I think last week my plastic surgeon said, they moved it to 7 years. So it goes back and forth. It also depends on which type of implant you have. If you had your own tissue used, then we don't routinely screen with an MRI. The purpose of the MRI really is to look at the integrity of the implant. So again, depending on the type of implant that you have, and the way that your plastic surgeon practices, an MRI is often warranted at some stage, some point, either 3 years, 5 years, and sometimes greater. And I think within the Plastic Surgery Society, they are still debating that.
Great. What are your thoughts on thermography instead of a mammogram to reduce radiation exposure?
Let me just jump in. We're going to take about 4 questions more because we want to be respectful of everyone's time. So this one and 3 more.
Great.
Okay.
So this is
And
an
we
easy
also
one.
have the poll.
I'm not completely sold on thermography. And, I'll sort of just say that we need more data to support the use of that. It's not, and again, it's not a great alternative when we know that there's a disparity that exists. I would say, we want to use the best tools possible. And when you think about the radiation exposure, I want to be clear that the radiation exposure is just like getting on the plane and flying from New York to California, and that's once a year. And there's nothing that supports the fact that that when done conservatively, the risk outweighs the benefit.
How can we encourage our sisters to participate in clinical trials? What would a basic conversation with them sound like?
I think this is a fun one. I think a great way to I sort of did, but it really is a great, because I love it, right? I love when I know that there's great opportunity to impact our community. So if I had a conversation with my cousins who are very diverse in their thinking, I would say, let's just take even well, I'm not going to go into COVID. I won't talk about COVID, but let's just say I'm having a conversation with a cousin, one auntie. I would say that, I understand that there are historical there were bad things that were done historically to us. But we should not allow that to dictate the therapies that we receive and representation. Right now, more than ever, it's important for our voices to be heard. And to participate in the clinical trial is allowing your voice to be heard. You don't want others' voice to be heard and we're sort of left on the side. That's not what we want. And so that's what I would say. And that clinical trials have a negative, a negative aura associated with it, not only because of that, but because people think that, there are things that are done without their knowledge. And I, being a researcher, know that there are thousands of hurdles that have to be undertaken at this point to get any clinical trial approved. And so that's the conversation that I would have.
Let me just interject really quick. We're going to put up our poll because in the interest of time, we want to make sure that everybody gives us some feedback so that we can continue to serve you in the best way possible. So while we finish up these last questions, if you'd be so kind to take the poll while it's open, we need you to give us some feedback. And before we go back to Dr. B, I just want to, again, shout out to our chapters and to the amazing participation we've had today. Not only from our chapters, but from just women around the country. Just again, some of our chapters that are on today: Southeast Wisconsin, Chicago, Detroit, New York, Triangle, North Carolina, Essex County, Greensboro, North Carolina, Austin, Orlando, Sisters Network, Central Virginia, Reading, Pennsylvania, Northeast Florida, Hampton Roads in Virginia, Tampa Bay, Nashville, Passaic County, New Jersey. We are so blessed to have those boots on the ground, those ladies who are doing the good work in the communities around the country. Without them, there is no Sisters Network. And that's why we are so different from other organizations, because we have those women out there serving in the respective communities. So we thank you, ladies, for all that you do. And thank you for being on today. And thank you to the upcoming chapter representatives who are on today from Montgomery, Alabama, Boston, Rochester, New York, and Phoenix. We're excited to have you come on board and finishing up your onboarding process. So we're looking forward to that. And we have just some representation from our sorority sisters out there, organizations: Alpha Kappa Alpha Sorority Incorporated, Delta Sigma Theta Sorority Incorporated, of course, Sigma Gamma Rho Sorority Incorporated is in the house, and the Links Incorporated women's organization is in the house. We thank you, thank you, thank you. And again, to Pfizer, ASI, and Seagen, who are our sponsors for today, we thank you again for all that you do. We'll turn back over the floor to Bernadette and Dr. B. And just real quick, we have a new partner on, a potential new partner on care access. So Dr. Mikkel Frazier, thank you for being on there and for putting some questions in the chat. I'll turn it back over to you, Bernadette.
Thank you. Dr. B, what are your...
Can I just jump in real quick?
Yeah, go ahead. I'm sorry.
Real quick. There's a question here that I want to make sure we answer. It's from an anonymous, someone who sort of put it anonymously, which is, I think, a great question.
That was the question I was about to ask you about the CBD products.
I want to make sure I'm not avoiding that question because I think it's a great question. And my answer is I am.
Say the question.
What's the question? Go ahead and ask the question.
Okay. They were asking, what are your thoughts on CBD products for cancer patients?
Okay.
Yeah, and my answer to that is, I think that within the guidelines of being treated by a physician and having some oversight, that it could be a tool that can help, and certainly we need to continue to look at it and see and do research, but I am in support if it helps, and it has helped many people with other medical issues and with other cancers. That's something that it's a pathway that we should explore.
Hey, that survey is open. I don't see the participation, so I need.
That's because the survey, we find that it's not calculated for some reason.
So people are filling it out.
They're answering slowly. They're coming in.
Okay, all right. Well, please, ladies, if you could continue, and gentlemen, can you please? Some people are having some problems with submitting. They're saying in the chat. So this is that's not good. Well, hopefully we can work that out. So please continue to fill it out, and we'll see what we can do on the back end to correct that. Bernadette, go ahead. Sorry.
Okay. There's another question here regarding the sons of breast cancer survivors. At what age should they start having tests done?
So they should. It goes back to the question of, is the survivor a genetic positive person? If they are, then the sons follow the same guidelines as the daughters, and should have assessment as early as 25. If they are not, for example, a BRCA carrier, then the son should, I would just sort of have the sons have that risk assessment again at the age of 30. And if you haven't been tested again, we know that there is also a disparity in testing for Black women. Seek out a geneticist or a physician who can provide you with a genetic counselor to have that testing done so that you can then be more empowered. Right. And I do want to give a shout out to my sorors who joined today, Sigma Gamma Rho, Sorority Incorporated. I am Legacy, and I'm just so thankful to be here. I know that they sent out a shout out, so some of them were going to join. Ms. Jackson, and I know that from an international standpoint, we are in full support of addressing this breast disparities crisis. So,
great. Caleen, do we have time for one more question?
Yeah, take one more, and we'll start to try to wrap up.
Okay. Regarding breast density, does the size of the breast determine the density, whether or not it's going to be dense?
It does not. And let me just say, breast density, because we throw it around like a, that is so negative. It's not negative. 50% of women have dense breasts. It's just, you need to know that you have dense breasts as a first step. And then as a second step, you need to know what to do about that, which is the ultrasound MRI. But it does not matter your size. You can have, large breast and have dense breast. You can have small breast and not have dense breast. It is how we view your breast tissue on mammogram. The mammogram, another sort of analogy to sort of think about is a blackboard. You have a blackboard, okay, that's a clean slate. That's fatty breast. I took a mammogram and you saw that blackboard, and I threw some salt on the blackboard, calcifications, let's say that's cancer, I can see that easier. If I took a white chalk and I drew all over the blackboard, that's dense breast. If I threw that same salt up against that blackboard with white chalk, it's difficult to see it. You can't see that well with the mammogram. So that's why you need other tools to look at the breast. It doesn't matter how much tissue is there. It's really the composition of the tissue.
Thank you. I know that you're going to share the link with Caleen, so that way she can post it on the website. Can you also share the age chart? Someone was interested in having that as well.
Sure, absolutely.
Okay. Dr. B, is there any parting comments that you'd like to make to the attendees today? We've had like a really robust conversation today. We really thank everyone for putting in their questions and engaging with Dr. B. This is what's important, to get those answers and to have that one-on-one chat with someone of her esteemed background. So I'll leave it to you to make a few parting comments, and I'll do some housekeeping things before we get off.
I'm just so excited to once again to have been invited to be here on this platform. This was such a robust, wonderful conversation on a Saturday afternoon, which always gives me the energy that I need, believe it or not, to go on through the rest of the week. And so, I want to encourage you all to continue to ask your questions, to continue to be an advocate for yourselves. This is a wonderful organization. You have wonderful leaders who have your back. And so, half the battle is speaking up and recognizing that, that there is a problem. And sometimes we all just need a little bit of help or a little bit of encouragement. So thank you, Ms. Jackson, for having me here. Thank you to the Sisters Network. And, Happy New Year.
Thank you again, Dr. B. And just to kind of close out, we thank you again, everyone, for your participation, for taking time on a busy Saturday. Just a quick housekeeping. We have our Stop the Silence Walk, the 12th annual Stop the Silence Walk. It's the only national African-American breast cancer walk in the country. We're super excited. The flyer was up there, if we can put that back up. Please come to Houston. It will be a wonderful time of sisterhood. We will be hosted on Saturday, April 23rd at Discovery Green Park here in Houston, Texas. And a portion of the funds raised from this event benefit the Breast Cancer Assistance Program, which many of you may be familiar with, that allows us to provide financial assistance to survivors around the country, as well as pay for mammograms, early detection mammograms for women who are uninsured or underinsured. Registration is open right now, and we look forward to seeing everybody come out and run and walk and celebrate survivors and just the camaraderie. So we're looking forward to that. And we also will have a Pink Power Tour that will be coming up later in this year. You'll hear more about it on our calendar of events. It's part of our Young Sisters initiative. It's called Pink Power Tour, Triple Negative Talk with My Sister. So we're very excited. We'll be visiting 5 cities, which we have chapters in. And you'll hear more information as we develop that program. And we'll be working with our chapters in those 5 selected cities. So lots of great programming coming up. It's a great year. We thank you for helping Sisters Network continue to be a leader in the national Black breast cancer movement for nearly 3 decades. We are so proud of that. We can't do it without your support. Of course, the survivors who are out there in the boots on the ground in the cities in which we have chapters. If you're interested in starting a chapter in your community, please contact us. If you go on our website under chapters, you will see the information. And we just look forward to continue to serve you. So please have a wonderful afternoon. Thank you again, and be blessed. Thank you.
Thank you.